Hello everyone, let's start the second part of your cardiovascular system. In this video, you're going to learn the rest of the cardiovascular system which we had. And the most important concepts you'll be learning in this video. So first and foremost is every NORCET paper is having an ECG based, image based MCQ or management based MCQ or a nursing intervention based MCQ. So it is very important to analyze each and every strip. Okay, you have to identify and make a diagnosis and make a conclusion what kind of a tachyarrhythmia, what kind of a bradyarrhythmia it is, right? So even if they give a normal ECG strip also, you should be able to find out whether it is a normal strip or an abnormal strip. So it is very, very important session. So let's get into it. So first is you're going to see about the normal sinus rhythm. First is about the normal sinus rhythm. What is meant by a normal sinus rhythm? As the name implies, it is the normal rhythm which is happening inside the heart. A normal patient will be having this particular normal sinus rhythm. So the rate will be around 60 to 100 beats per minute. That is, your heart rate will be around 60 to 100 beats per minute, and the regular rhythm will be there. What does mean by a regular rhythm? Regular rhythm means a normal rhythm. Each and wave is consecutively happening. For example, the electrical conduction system starts from the SA node to the AV node to the bundle of this and to the Purkinje fibers. So this is particularly calculated in the electrocardiography, right? ECG is monitoring the electrical conduction system of the heart. That is the basic concept which you all know. So if this is happening, the proper deflection will be happening in the ECG, which means each and every cardiac cycle will be having the P wave, the QRS complex, and the T wave consecutively. So if everything is happening properly in a regular interval, that is termed as a regular rhythm, which means every P wave is following its QRS complex and then T wave, and the cycle is very regular and there is no prolongation or no narrow complex of the QRS is happening. So that we term it as a regular rhythm. Next, P wave before the QRS complex. Every P wave is having a QRS complex, its respective QRS complex, and the PR interval, which we have discussed earlier, it is always normal, that is 0.122 to 0.20 seconds. The PR interval is calculating the amount of electricity which is conducted from the atrium to the ventricles through the AV node. So, the clinical condition which is indicating normal sinus rhythm, yes, it is obviously normal, and you will be continuously doing a monitoring. So now let's see the ECG of a normal sinus rhythm. So for example, how I'm calculating it is a normal, how I'm coming to the conclusion it is a normal rhythm. So this is the P wave, this is your QRS, and this is your T wave. So again you have P wave, QRS, and the T wave, P wave, QRS, and T wave, P wave, QRS, and T wave. So this is so regular, like each P wave is having its respective QRS complex and it is happening in a proper way. So next we are going to calculate the heart rate of this ECG. So I said you the best method and the easy method is the large square method. What is the formula for large square method? For large square method, it is 300 divided by number of large boxes in 1 RR interval. So here this is the 1 RR interval. So now we are going to calculate the number of large boxes inside the 1 RR interval. So this is 1, this is 2, and this is 3. So 300 divided by 3. So 300 divided by 3, as you all know, 3 ones are 3. So it is 100 beats per minute. The heart rate you have calculated, it is 100 beats per minute. So it is a normal ECG because everything is having in a synchronized manner. Every P wave is having its respective QRS complex, and the heart rate is also 100 beats per minute, and it is regular. Okay. So now we will see the PR interval. So this is the PR interval starting from the P wave to the end of the QRS complex. The normal PR interval is 0.1 to 0.20 seconds, as we discussed earlier. In case of box calculation, you can remember in such a way, in box calculation of PR interval. Okay, box calculation of PR interval, it will be always calculated with the help of the small boxes. It will be around 3 to 5 small box. It will be around 3 to 5 small box. So it is indicating that it is a normal PR interval which is between 0.1 to 0.20 seconds. So here to be very precise, so let me calculate the number of small boxes. 1, 2, 3, 4, 5. So it is 5 small boxes in the PR interval. So it is indicating a normal ECG. So this is all about your normal sinus rhythm. So next we are going to sinus bradycardia. As you all know what is meant by bradycardia. Bradycardia means decrease in the heart rate. The other term which we have is bradyarrhythmia. So what does mean by bradyarrhythmia? Bradyarrhythmia means when the heart rate is going less than 50. Is going less than 50 beats per minute. You are terming it as bradyarrhythmia. So bradycardia, you are telling it is 60 beats per minute. When it is less than 60 beats per minute, you are telling it is bradycardia. Whereas bradyarrhythmia, it is going less than 50 beats per minute and it is having some rhythmic alterations, then you are telling it as a bradyarrhythmia. So in sinus bradycardia, the heart rate will be less than 60 beats per minute and the rhythm will be regular. There will be no abnormalities in the rhythm, but the heart rate will be reduced. Each P wave will have its own QRS complex, everything will be normal, but the heart rate is reduced, which is less than 60 beats per minute. So the normal PQ or ST sequence, there is no alteration in that. Okay, the P wave will be having its QRS complex, the normal PR interval will be there, the QRS complex will be normal, everything will be normal, but the impulses is less, which means the heart rate is less. So this happens because the athletes and vagal stimulation. So these athletes, when they have increased activity, what happens? It increases the pulmonary intrathoracic pressure. Whenever the pulmonary intrathoracic pressure is increasing, this is in turn going to stimulate your vagal nerve. The vagal nerve is your 10th cranial nerve, as you all know. This 10th cranial nerve is stimulating the parasympathetic activity of your cardiac conduction system. So what does mean by this? A parasympathetic activation. As I said you, any sympathetic activity is going to, any sympathetic activity of the sympathetic stimulation is going to increase the heart rate and contraction, as I said you earlier in the previous session. There is parasympathetic component. What it is going to do? Parasympathetic component is going to decrease the heart rate and it does not have a specific effect on the contraction, right? So here parasympathetic activity is going to decrease the heart rate. That is the ultimate point which you have to note. So in this case, in this athletes, and when we do vagal stimulation, that is the activation of the 10th cranial nerve, stimulating the 10th cranial nerve, it is going to in turn stimulate the parasympathetic activity. This parasympathetic activity will work on the baroreceptors and it will decrease the heart rate. So ultimately, the normal function which is happening is to decrease the heart rate. So it is going to work on the baroreceptors and it is going to decrease the heart rate. Right? This is what is happening when the vagal nerve is stimulated. That is your 10th cranial nerve. And when there is an inferior wall MI. And the most important point, please understand, dear children. As we discussed in the previous session, inferior wall MI, the blood supply of the inferior wall of the heart is done by which particular artery? It is particularly done by your right coronary artery. As you all know, it is particularly done by your right coronary artery. It is done by your right coronary artery. Whenever there is a block and the myocardial infarction is happening because of the blockage of the right coronary artery, it is going to have a severe impact towards your AV node and SA node, because from there only, from the right coronary artery only, the SA node and AV node is getting a blood supply. So when there is an occlusion in the right coronary artery, it is going to rapidly have an effect towards the functions of your AV node and SA node. So when there is an inferior wall MI, which is because of the right coronary artery occlusion, this is also again going to cause bradyarrhythmias. Okay, it is also going to cause bradyarrhythmias. So here the important management is, first you have to assess the perfusion status. If the patient is stable, you have to analyze. If the patient is hemodynamically unstable, we are going to administer atropine. Okay, atropine 3 mg we are going to administer. Okay, atropine 0.5 mg we will be starting. Maximum dose we can give is 3 mg. So first you have to assess the perfusion status of the patient. If the patient is stable, you are going to monitor the patient. If the patient is unstable and if this hemodynamical stability is not achieved, in this case you are going to give atropine. So you are going to start with 0.5 mg. You are going to start with 0.5 mg. Maximum you can give 3 mg. Maximum you can give 3 mg. An important question. Okay. So here you can see this is a 6-second ECG strip. This is a 6-second ECG strip, and here you are going to monitor the heart rate of the patient, right? So as we discussed earlier, the heart rate is going to be only component which is going to be reduced in case of sinus bradycardia. The other component, if you see, there is a P wave, there is a QRS, and the T wave. So P wave, QRS, and the T wave, P wave, QRS, and the T wave, P wave, QRS, and the T wave. So it is regular. Okay, so each P wave is having its own QRS complex, and this particular component is regular rhythm as well. So if you see the heart rate, the RR interval is quite widened, which means the heart rate is less. So how we will calculate the heart rate? Same method we will use, that is the 300 technique we will use. Okay, so 300 technique, what is the 300 technique? So now I am going to calculate the heart rate. So this is the RR interval. Okay, this is the RR interval. This is the RR interval. And now how many number of large boxes you have? 1, 2, 3, 4, 5, and 6 large boxes you have. 6 large boxes you have. Okay, you have 6 large boxes. Now you are going to do 300 divided by 6. 300 divided by 6. So here you have 300 divided by 6. So as you all know, 6 5s are 30. So it is 50. So obviously the heart rate is what? It is reduced. It is less than 60. So it is 50 beats per minute, which means it is the bradycardia, right? So next we have the sinus tachycardia. The sinus tachycardia, as we discussed earlier, it is the increase in the heart rate. So the heart rate will be greater than 100 beats per minute. The heart rate will be greater than 100 beats per minute. Here also, if you see, the rhythm is going to be regular only. Here also there is no any abnormal changes in the rhythm. Every P wave is going to have its own QRS complex, and it is going to be regular only. The P wave before QRS complex is present, which means every P wave is going to have its QRS complex, and the rate is very much it is regular. So, but the heart rate is very much increased in case of your sinus tachycardia. The heart rate is very much increased in case of your sinus tachycardia. And the most important point you have to note is sinus tachycardia means it is greater than, okay, tachycardia means it is, the heart rate is greater than 100 beats per minute. Okay, when it is a tachyarrhythmia, it is a tachyarrhythmia, if it is a tachyarrhythmia, it will be greater than 150 beats per minute. Okay, this is the definition. If it is a tachyarrhythmia, it is going to be greater than 150 beats per minute. So, when the patient will be getting sinus tachycardia, the patient will be getting fever. In case of hypovolemia, in case of anemia, in case of exercise, or in case of excessive anxiety, in this case, the patient will go for a sinus tachycardia. So you have to treat the underlying causes, and you have to give the antipyretic medications, fluids, and electrolytes. As you all know, for every rise in 1 degree of temperature, there will be a rise in 10 heartbeats. Okay, and there is a very common sign for that, and that is a homework for you. You have to find what is that common sign. When there is a rise of 1 degree temperature, there will be a rise of 10 beats. So what is the condition behind it? You have to check. So now coming back to the ECG, you can see every P wave is there, and every P wave is having its own QRS complex. P wave QRS T, P wave QRS T, right? So again, so if you see the RR interval, and if you are going to calculate the heart rate, it is 2 boxes. 300 divided by 2. So 300 divided by 2 is 150 beats per, which means it is a sinus. It is even going for a sinus tachyarrhythmia also. Okay. So here you have 2 large boxes. And the numerator should be 300 when you are calculating the large boxes in the heart rate. So it is 150 beats per minute. So as I said you, when the heart rate is greater than 100 beats per minute, we are terming that, so it is a tachycardia. So when we are calculating the heart rate of this particular ECG strip, it is 150. So when it is going more than 150, it will go to the case of tachyarrhythmias, right? So here it is the case of sinus tachycardia. And since the ECG is also very regular and the rhythm is very regular, every P wave is having its respective QRS complex and T wave. So we are telling it is a regular rhythm. So you have to note in that manner only in the ECG. So next we are going to talk about the most important abnormal ECG findings. First is your atrial fibrillation. So in atrial fibrillation, it is an irregularly irregular. It is an irregularly irregular. So everything is irregular in this. Okay, and there will be no P wave. Absence of P wave. P wave absent. E wave is absent. E wave is absent. Okay. Variable ventricular response. There will be variable ventricular response in case of your atrial fibrillation. And the most important thing you have to see, what does mean by irregularly irregular rhythm? Irregularly irregular rhythm means there will be irregular RR interval. There will be irregular RR interval. So if you can see the RR interval in the first cycle and in the second cycle, and see here, the RR interval is very much irregular. So this is the classical finding. You can identify that the patient is on atrial fibrillation. Atrial fibrillation, the first and foremost point you have to remember, it is an irregularly irregular rhythm. Okay, which means there will be so much irregularities in the RR interval. Okay, there will be so much interactions, so much disruptions in the RR interval. And the most important is atrial fibrillation. Think the patient will not, the ECG is not going to have the P wave. The P wave is absent. The P wave is absent. So if you can see the ECG now, so here you see the QRS complex is so prominent. The QRS complex is so prominent. The QRS complex is so prominent. Okay, but you cannot see the P wave. The P wave is buried somewhere. The P wave is buried inside the QRS complex and P wave. So that is the concept behind this atrial fibrillation. So atrial fibrillation will be seen in which of the conditions? So elderly patients will be having the higher risk. Hypertension patients in valvular heart disorders. In case of thyrotoxicosis, that is also having interaction with the atrial fibrillation. So what is the management of atrial fibrillation? First is you have to start with the anticoagulant therapy. Okay, rate control and rhythm control you have to do. Okay, for rate control, first and foremost you have to do is the administration of the beta blockers. So what is the ultimate action of the beta blockers? It is beta blockers works on the principle. The action of beta blockers. What is the action of beta blockers? The action of beta blockers is to block the AV node. Okay, block the AV node. Okay, in order to control the heart rate, we are going to give this beta blockers or glutiazide. Next is anticoagulants. Why anticoagulants is very important is this particular atrial fibrillation is having the highest risk to cause thromboembolism. Thromboembolism. This is having the highest risk to cause thromboembolism, and it can obstruct the pulmonary circulation. Right. To avoid this only, we are starting the anticoagulant therapy to this particular patient with the warfarin and apixaban. Okay, apixaban. Okay, so this is the atrial fibrillation strip. You can see. So next we are going to talk about the atrial flutter. The classical sign of atrial flutter is the sawtooth appearance. Sawtooth flutters. This is the sawtooth flutters you can see. This is the sawtooth flutters which you can see in case of your atrial flutter. So, which is otherwise we are terming it as F waves. So the arterial rate will be around 250 to 350 beats per minute. The atrial rate will be more than 250 to 350, like which means the atrial contraction will be so prominent and it will be without having a proper synchronization, which means the atria has to contract and the ventricle has to fill and the ventricular contraction should happen so that it goes to systemic circulation. But in this case, what happened? Without having a proper mechanism, the atria will start contracting in a very rapid manner. That is termed as your atrial flutter, right? So here the atrial rate will be around 250 to 350 beats per minute, and it is a regularly irregular rhythm, which means there will be regular RR intervals, but it is a irregular rhythm, which means it will not have a proper P wave and its QRS complex like that. It has a sawtooth appearance between each waves, right? So that is the thing. Atrial flutter is most commonly seen in case of your chronic obstructive pulmonary disease, which is a combination of two conditions, that is chronic bronchitis and emphysema. And in valvular heart diseases also, this atrial flutter is having higher chance to come. Next, we have the management. What is the important nursing responsibility? First, we have to give the rate control medications, and if the patient is going to be a severe condition, in this case, we are going to give cardioversion and anticoagulants to this patient. Okay, so this is your atrial flutter ECG strip. The classical sign you have to understand is the patient will be having a sawtooth appearance and the heart rate is going to be around, the atrial rate should be going to be around 250 to 350 beats per minute. And it is a irregularly regular, okay, regular or irregular. Okay. So next we have the supraventricular tachycardia, where there is a lot of MCQs asked from supraventricular tachycardia. So this is the supraventricular tachycardia's ECG you can see. First and foremost, you have to know there will be a narrow QRS rhythm. Supraventricular SVT is a narrow QRS rhythm. I said you what is meant by narrow QRS rhythm. The normal QRS duration is 0.08 to 0.12. Okay. The normal QRS is 0.08 to 0.12 seconds, right? So in this case, when the QRS is less than 0.08, in this case, we term it as a narrow QRS. So that is seen in case of your supraventricular tachycardia, which means in the superior portion of your heart, this tachycardia is happening in the superior portion of your ventricles, right? And there will be a regular rhythm and the rate will be 150 to 250 beats per minute. There will be a regular rhythm and the heart rate will be 150 to 250 beats per minute. It is because of any kind of stimulant, stress and heart diseases, and the management of SVT is the most important thing you have to definitely remember. The management of SVT is based upon the stability of the patient. Okay, the management of SVT is based upon the stability of the patient. For example, if the patient is stable, okay, we are going for normal observation and we are going to give vagal maneuver to this patient. So, if the patient is unstable, here where the important management starts. So here you are going to, initially first we will give the vagal maneuver. So what does mean by vagal maneuver? That is the most important component you have to learn here. What does mean by vagal maneuver? Vagal maneuver is nothing but, the stimulation of the vagus nerve. Stimulation of the vagus nerve, as you all know. Okay, vagus nerve is your 10th cranial nerve. So this stimulation of this vagus nerve is going to cause the increased parasympathetic stimulation. Okay, it is going to increase the parasympathetic nervous system stimulation. So what this is going to affect? This is going to affect on the baroreceptors and parasympathetic nervous system. Always what it is going to do? It is going to decrease the heart rate. So that is why we are going to give this vagal stimulation. So vagal stimulation, what are all the types of vagal stimulation? Okay. So types of vagal stimulation. First is your Valsalva maneuver. What does it mean by Valsalva maneuver? Valsalva maneuver is like a patient is in a sitting position, in a normal position. What you have to do, you are asking to forcefully exhale from all the orifices. Like you are asking to forcefully exhale out. Okay, forcefully exhaling out into the syringe or into manually. So that is termed as Valsalva maneuver. Forcefully, I am asking to exhale the patient where all the orifices is getting pressurized and down. So when this forceful exhalation is happening, the intrathoracic pressure is going to increase, which in turn going to cause the vagal stimulation, and thereby the heart rate is going to decrease. Next is, this is the normal Valsalva maneuver. We also have the modified Valsalva maneuver. So first I said you Valsalva maneuver is forceful exhalation. Through all the orifices. So modified Valsalva maneuver is your Valsalva maneuver plus, okay, Valsalva maneuver plus the patient is in the supine position, supine or lying position, plus rise of limbs, rise of limbs. This is the modified Valsalva maneuver. Okay, Valsalva maneuver is forceful exhalation through all the orifices, either blowing into the syringe or like that. But modified Valsalva maneuver is accompanied with Valsalva maneuver plus the patient is in supine or lying position, plus you're going to elevate the lower limb of the patient once this forceful exhalation is done. This elevation is done only to because what is the primary purpose of this rise of lower limb? That is to increase the venous return. It is to increase the venous return. Increase the venous return. Increase the venous return. Okay. And stimulation of the gag reflexes also going to increase your vagal stimulation and thereby causing the decrease in the heart rate. AV nodal block can be promoted. And dipping of face into an ice water. This is also going to stimulate your vagal nerve. Okay. Face to ice water. So these are all the other types where you can do the vagal maneuver, right? So coming back to your SVT management, first is your stable VT. Stable, in case of stable, the patient is hemodynamically stable. In this case, what we are doing the vagal maneuver and we are trying to revert the patient. When the patient is going for unstabilization, first we are going to do the vagal maneuver. Okay, vagal maneuver. If the patient is not stabilized, we are going to give adenosine. We are going to give injection adenosine, 6 mg IV, rapid push. So I have my actual life experience towards this SVT patients where I was working in an intensive critical care unit. Suddenly the patient got supraventricular tachycardia. We were getting ready. I am a junior nurse at that time. So what happened? My senior started doing a vagal maneuver. Okay. And another one point you have to remember, carotid massage. Okay, your carotid artery massage. Okay, carotid artery massage also causes vagal stimulation, which means only one side you have to do. Okay, it is contraindicated if the patient is having carotid roots or if the patient is an elderly patient, you should not do carotid artery massage, right? So there is limitation in moving and performing carotid artery massage, but carotid artery massage is also one of the component under your vagal maneuver, which causes the stimulation of the parasympathetic nervous system by stimulating your vagus nerve. Okay, so coming back to the management of SVT. So I was a junior nurse at that time. What happened? Like the patient got sudden SVT, and like we know how we study in BSc nursing, right? So the same way I went into an anxiety attack. The patient is in SVT, and I went to an anxiety attack. So what happened? My TL was rushing to adenosine. So what happened? Suddenly, what they have done? The cardiac monitor is showing the SVT rhythm. Okay, so you can see here, this is the SVT rhythm. The cardiac monitor is showing the SVT, narrow QRS complex, and the heart rate is getting more than 250. And this is happening. And what happened? Started giving vagal maneuver. There is no response. Once there is no response for vagal maneuver, we will go and administer adenosine, injection adenosine, one of the most important drug which is administered, with the drug of choice for SVT. So what happened? You are going to administer the adenosine. How there is a procedure for administering adenosine also. They will be establishing a large bore IV catheter in the left arm of the patient. So what happened? Once they establish the large bore IV catheter in the left arm, they will be giving an adenosine 6 mg in a rapid push, and followed by you're going to give 20 ml of NS. Okay, then the patient will be given 20 ml NS, normal saline rapid flush. So once this rapid flush is given, suddenly what my TL done? She has lifted his hand above the head, and what happened? And there is a sudden asystole. Okay, there is a sudden asystole, and there is a rhythmic change. Okay, there is a rhythmic change. The patient recovered from SVT. So this is what has happened after administration of the adenosine. Once the adenosine is administered, and the shelf life of the drug is very 10 seconds. The shelf life of adenosine. Okay, the shelf life of adenosine is only 10 seconds. So rapid push you have to do, and you can see immediate change in the cardiac monitor. So that is the classic feature of this drug adenosine. When the patient is not reverted even after adenosine, then we are going for cardioversion. cardioversion, that too synchronized cardioversion. Synchronized cardioversion. Right? Synchronized cardioversion we are going. So next, you see the ECG pattern of the supraventricular tachycardia. The patient is having a very narrow complex QRS, Okay, the patient is having a very narrowed QRS complex, and you can see the P wave is buried. P wave is buried. The P wave is hidden. Okay, the P wave. Okay, the P wave is buried. P wave buried. Okay, the P wave is buried, and the heart rate, you can see it is. See if you can calculate the heart rate manually. You can calculate because we have done a lot of problems on that. So the heart rate is going to be more than 250 beats per minute. Okay, right. If the patient is going to be unstable, we are going for adenosine and cardioversion. So next we have the ventricular tachycardia, the another important ECG which you always get. So this is the classical ECG pattern of your supraventricular tachycardia. Always try to remember these images. Okay, these images, because at the last minute the image based questions can be asked. So you should have a quick review. So next we have the ventricular tachycardia. This ventricular tachycardia, like supraventricular tachycardia, is a narrow QRS rhythm. Okay, narrow complex QRS rhythm. Whereas your ventricular tachycardia is wide QRS complex. Okay, it is a wide QRS complex abnormality. It is a wide QRS complex abnormality, which will be greater than, your QRS duration will be greater than 0.14 seconds. It will be greater than 0.14 seconds. It will be greater than 0.14 seconds. Right. And here also the regular rhythm will be there, and the rate is going to be greater than 100 beats per minute. So when you see a wide QRS complex rhythms with the regular rhythmic pattern, you have a wide QRS complex which is greater than 0.14. In this case, you're coming to the conclusion it is the ventricular tachycardia. Okay, ventricular depolarization is indicating what? The QRS complex. So ventricular tachycardia is going to have a wide QRS complex ranges, which is going to indicate it is a ventricular tachycardia. So VT is seen in which of the condition? VT is seen in MI, electrolyte imbalances, and cardiomyopathies. And what is the management of VT? If the pulse is present, you're going to give synchronized cardioversion. Very, 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 very important points to note. If the pulse is present, you're going to give a synchronized cardioversion. What does mean by synchronized cardioversion? Synchronized cardioversion means the electrical impulse, okay, the shock will be delivered, okay, the shock will be delivered by sensing the R wave, by sensing the R wave, by sensing the R wave, or we can tell it is a timed shock. Timed shock. The shock will be delivered at the R wave. When the R wave peaks, when the R wave peaks. So these are all key terms which you have to note. When the R wave peaks, the shock is delivered. That is termed as your synchronized cardioversion. Asynchronized cardioversion. So here in asynchronization, it will not target the R wave. It will just like that give the current, give the shock. So next, if the VT is pulseless, you have to start the CPR immediately and defibrillation is proceeded. Okay, and defibrillation is proceeded. For VT and VF, you're going to start the CPR and defibrillation. Please remember this. If the pulse is present, and you're going to give the synchronized cardioversion. If there is no pulse, how the cardioversion can able to detect the R wave? It is not possible, right? So that's why you're going to start the defibrillator, right? So if the pulse is present, you're going to give cardioversion. Okay, for VT, if the pulse is present, you're going to give for cardioversion, synchronized cardioversion, specifically at the R wave you're giving. And if the pulse is absent, in this case, you're going to start the CPR immediately and you're going to give the defibrillation, right? So defibrillation is an asynchronized method because here it cannot sense, if the pulse is not present, it cannot sense the R wave and deliver the shock, right? So that is the common sense behind that, right? So it is very, 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 very important. VT management is very, 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 very important. So kindly note it. So next, this is the rhythm of ventricular tachycardia. Always remember the pictures, which is very, very important for your examination. right? So next we have the ventricular fibrillation. Next we have the ventricular fibrillation or VF. Ventricular fibrillation is the most chaotic and irregular deflections you can see. The ventricle starts to fibrillate and generate its impulses like anything, and it will start contractions, right? So that is the ventricular fibrillation. So it is will be chaotic and it is an irregular deflection. In ventricular fibrillation, in VF, you have coarse VT and fine VT. Coarse PT, it is like very much irregular, very much irregular. You cannot differentiate which is P wave, which is QRS complex, which is T wave. Nothing you can able to differentiate in case of your ventricular fibrillation. So this fine VT, it will be quite, the deflections will be quite fine. Here it is totally abnormal, but here in fine VT you can see. So this is how you can able to differentiate between your VF of coarse VF and your fine VF. Okay, so not identifiable P wave and QRS complex. When VT is not treated properly, this will lead to ventricular fibrillation. When VT is not treated properly, this is going to lead to ventricular fibrillation. So sudden arrest and MI and electrocution. The most important MCQ point which you have to note is, what is the most common cardiac arrhythmia which comes after the patient is on electrical shock? Electrocution is the electrical shock. Okay, because of shock, the patient is getting an cardiac arrhythmia, which is the most common arrhythmia, which is happening post electrical shock kind of situations. That the answer is ventricular fibrillation. Electrocution, the most common arrhythmia which is seen as your VF. MCQ point. Right? So sudden cardiac arrest, MI and electrocution, in this case ventricular fibrillation is seen. When the VT is not managed properly, it will lead to ventricular fibrillation. So what is the management of ventricular fibrillation? Immediate CPR, immediate cardiopulmonary resuscitation plus defibrillation, and as per ACLS protocol, you will be going. So here you can see the coarse and fine VF. Okay. Next we have asystole. Asystole means what? Absence of pulse. Okay, no electrical activity. There is a flat line and there is a no electrical activity in case of cardiac arrest. Always remember two conditions: heart attack and cardiac arrest. Cardiac arrest is the problem in the conduction system of the heart, that is the electrical impulse generation. On the other hand, we have heart attack, that is because of the problem in the coronary arteries. When there is a block in the coronary arteries, which is going to lead to the myocardial infarction and ischemia. But cardiac arrest is a different condition where the heart stops because of the absence of electrical impulses. So when there is an asystole, confirm in two leads. So first you have to check the leads properly, placement of the leads properly. If there is an MCQ which is stating all the parameters of normal and suddenly the patient is showing asystole, in this case what is the immediate nursing management? They can twist the questions like that. Whenever you see an abnormal rhythm, first and foremost thing is you have to adjust the ECG leads properly. You have to see whether the ECG leads are placed properly. Then only you should come to the conclusion. You should not take a lot of time, but you should do this as a primary management. So first you have to confirm the ECG placement and you have to confirm this asystole is present in two leads. Okay, two leads, two consecutive leads. Then what you have to do, you have to start the CPR. You have to go on to start this cardiac pulmonary resuscitation. Then we are going to give a life-saving drugs, epinephrine. And in this case of asystole, you should not give defibrillator. Okay, asystole and pulseless electrical activity. Okay, asystole and pulseless electrical activity is having indication they are non-shockable rhythms. Okay, non-shockable rhythm. Now these basic questions are not asked, they are asking advanced questions. So you have to train yourself most advancedly. So this is asystole, you can see. This is asystole. This is the asystole pattern which you can see. Next, we are coming back to the most important, and possibly there might be questions can be asked from this particular component also, because we have questions period, not they were actually giving the ECG and analyzing, but they are giving about the nursing interventions and management and patterns. But you can ask the ECG questions also. First degree heart block. So you know heart block is a important condition. Heart block, we have three types of heart block: first degree, second degree, and third degree. Okay, so let me write here. You all know heart block. Heart block is first degree and second degree and third degree. Okay, first degree, second degree and third degree we have. So second degree is further classified into Mobitz type 1 and Mobitz type 2. Okay, so Mobitz type 1 and Mobitz type 2. It is further classified into Mobitz type 1 and Mobitz type 2. So first we are going to discuss about the first degree heart block. So first degree heart block, the PR interval is greater than 0.20 seconds. The PR interval, the normal PR interval as we learned is 0.12 to 0.20 seconds. The normal PR interval 0.12 to 0.20 seconds. When it is greater than 0.20 seconds, in this case, what you have to do, which means it is increased. The PR interval is prolonged. The classical thing which you have to analyze is first degree. The key word is prolongation of the PR interval. Prolongation of PR interval. Prolongation of the PR interval. Okay, which is greater than 0.20 seconds. Okay, remember? Yes. So regular rhythm, P wave is before each QRS complex, which means regular rhythm. When there is a word regular rhythm, P wave is going to have the QRS complex. Each P wave is going to have the QRS complex. But if you see the PR interval, the PR interval is prolonged. As I said, it should be only 3 to 5 small boxes. It should be only 3 to 5 small boxes. Here you can see 1, 2, 3, 4, 5 and 6, 7 boxes are there. So that's why it is termed as the prolongation of the PR interval. First degree heart block, always remember prolongation of the PR interval, and the PR interval is going to be greater than 0.20 seconds. When you see a word prolongation of the PR interval which is greater than 0.20 seconds, and if it is having a regular rhythm, every P wave is having its own QRS complex, then your answer will be first degree heart block. When your answer will be first degree heart block. So next, what is the management? What are the causes for first degree heart block? First is when the patient is getting a digoxin. The ultimate action of digoxin and your beta blockers is to block the AV node, and in case of any kind of ischemia, in this case also you have a bradycardia. Right. So first degree heart block will be caused because of digoxin, beta blockers and ischemia to the structure. So that are the causes. And usually first degree heart block is asymptomatic. First degree heart block is always, okay, it is asymptomatic, and it is asymptomatic. So there is only observation and monitoring only we will do. Okay. Okay, only observation and monitoring we will do. Next, we are going to the second degree heart block. Second degree heart block, as I said you, second degree we have type 1 and type 2. Type 1 is known as Mobitz 1 or your, okay, Mobitz 1 or your Wenckebach phenomena. Here, the important keyword you have to notice, progressive prolongation of the PR interval. Progressive lengthening of the PR interval until the QRS drops. Okay, progressive lengthening of the PR interval until the QRS is dropped. For example, if you see this ECG, here the PR interval, and here the PR interval, and here the PR interval, and here there is a drop in the QRS. Right. See, if you can see the the PR interval is progressively prolonging. The progressively it is getting higher. Okay, for example, in this it is 0.22, here it is 0.30, here it is becoming 0.40. Like that, the PR interval is getting progressively increased. At last, what happened? There is a loss of QRS. Loss of QRS or drop in the QRS. Drop in QRS. Drop in the QRS. Okay, the drop in the QRS is termed as your second degree heart block. Okay, that is termed as your second degree heart block. So what does mean by drop in QRS? Drop in QRS means from the SA node, okay, from the SA node, the impulses is reaching to AV node. From that, it has to reach the bundle of His and it has to reach the Purkinje fibers. Here, the AV node is the one component which is transmitting the impulses to the ventricles. These all are happening in the ventricles only. When the AV node is blocked, okay, first I'm sending, I'm trying to send. In the second attempt, I'm trying to send, but I'm even more delayed. In the third attempt, I'm trying to send, but I'm even more delayed. At last, I could not able to send to the ventricles. That's why there is a drop in the QRS complex. There is the drop in the QRS complex, which means progressive lengthening of the QRS complex, and then the drop in the QRS complex is termed as your second degree type 1 Mobitz 1 or the Wenckebach phenomena. When you see this pattern of prolongation of the PR interval, progressively lengthening pattern, you have to come to the conclusion it is a second degree heart block. So what is the cause? Obviously it is ischemia, digoxin and inferior wall MI. As I said you, right, coronary artery is the one which is supplying the blood to the your AV node and SA node. So when there is a block, it will lead to ischemia. So next you have to monitor atropine. Okay, so what is the management? So in second degree type 1, when it is not treated properly, okay, it may lead to the progressive condition. So you have to monitor, and the patient will be symptomatic in this case, and you have to administer atropine to the patient, into the patient. So atropine, as I said you have to start with 0.5 mg every 3 to 5 minutes. You are going to give the next dose and next dose, and you have to give 3 mg. The maximum dose you have to give is 3 mg only, not more than that. So next we are going to talk about the second degree type 2 or Mobitz type 2. In second degree type 2 or Mobitz type 2, you will be having a constant PR interval. Note it, children. In Mobitz type 1, you have progressive lengthening of the PR interval. But in Mobitz type 2, you are going to have a regular PR interval. Okay, you are going to have a constant PR interval, not a regular PR interval. It is a constant PR interval. Some dropped QRS complexes, but you will be having a drop in QRS complex, which is very prominent. Here, going, and dropping. Here, going, dropping. Like that, it is there. So that is called constant PR interval, but there is a drop in the QRS complex, which will be so drastic. Okay. So that is where we are terming it as 2:1 and 3:1 block. What is mean by 2:1, 2:1 or 3:1 block? Which means for every 2 P wave, there is a drop in QRS. Drop in 1 QRS. So that is termed as a 2:1, 3:1 block. Right. So the causes is anterior MI, conduction disease, prepare for pacing, risk for progressing to complete block. So the most important MCQ point here is when Mobitz type 2, okay, Mobitz type 2, that is your second degree heart block. In the second degree heart block also, when you have Mobitz type 2, when you are not treating it properly, it will lead to myocardial infarction, it will lead to further complications, and it is the one which is going to drastically lead the patient to the complete heart block. Complete heart block is your third degree heart block. Complete heart block is your third degree heart block. So you can see the Mobitz type 2 heart block here. The PR intervals or anywhere it is constant, but you can see there is lot of drop in the QRS complex. So this is what this is 2:1 block. This particular indicates 2:1 block. Okay. Next we are coming to the third degree. So third degree heart block is where there is no association between the P wave and the QRS complex, which means the impulses which is generated from the SA node, it is not transmitted from the AV node to the ventricle. So what will happen? Atria will contract on its own. Here, as I said you in the first class, that whenever the failure of SA node and AV node is happening, this Purkinje fibers has its minimal capacity to generate some impulses, right? So what it is doing, this Purkinje fibers also start to generate its impulses and start to promote the ventricular contraction and ventricular. So what happens? Atria will contract on its own, ventricles will contract on its own, right? So this in turn causes no association between the contraction. This everything should be happening so synchronously, right? Everything should happen so synchronously. In this case, there is no synchronization is happening. It is not happening synchronized. So that is termed as your third degree heart block or complete heart block, where the conduction system is completely failed and it is causing atria to contract on one side and ventricle to contract one side. The key point which you have to notice, atria and ventricle beat independently and there will be no relationship between the P wave and the QRS complex, which means there will be one P wave and there will be no QRS and P wave, no QRS. The rhythm will be like that. Okay, no association between the P wave and the QRS. No association between the P wave and the QRS is seen in this case. Okay, so here in Mobitz type 2, as we see, we have to start pacing. The most important point which we missed, okay, In Mobitz type 2, we have to start that transvenous or transcutaneous pacing. As per the availability, we are going to start the transcutaneous, which means the paddles you are going to attach for pacing, transcutaneous pacing. And in this case, and another case is transvenous pacing. So transvenous pacing is done most commonly through the femoral vein. So what they will do, they will be directly putting the electrode inside the heart. Okay, it will be a biventricular, okay, or it will be atrial electrode or a ventricular electrode or a biventricular electrode, which means it is placed in both the ventricles. So like that, it will be there. That is the transvenous pacing. That is the temporary pacemaker. It is a temporary pacemaker. Okay. On the other hand, we have the complete heart block, the only management. Okay, emergency transcutaneous pacing you will do, and the only management is permanent pacemaker. Okay, in case of complete heart block, you have to give permanent pacemaker only to the patient. Okay, so this patient will be needing electrical conduction externally through the permanent pacemaker which is implanted. And there is a lot of limitations for these patients, like in airports and all, they should always carry a tag that they are having a pacemaker, and they should not be exposed to severe electromagnetic field in MRI in those cases and all. And they have a separate entry in airports and all. So these are the considerations and advices you have to give to that particular patient. And advice regarding the battery, the working capacity of the battery may be 10 years or more than that. Those kind of instructions should be given to those particular patients. Always they have to monitor their rate, rhythm, and rhythm specific kind of various types of pacemakers are available. So that and all, you have to give the patient education in this case. But here, while pointing out the ECG, you have to see that there will be no association between the P wave and the QRS complexes seen in this case of your complete heart block. So next we are going to see about ST elevation. As I said you, ST segment is an isoelectric segment. What is the key here? ST segment. Okay. ST segment is an isoelectric line. Isoelectric line. ST segment is an isoelectric line which is not having any kind of electrical impulses. It is a early ventricular repolarization state. It is a early ventricular repolarization state. Early ventricular repolarization state, right? Early ventricular repolarization state. So when there is an ST segment elevation greater than 1 mm in two consecutive leads, there is an elevation of more than 1 mm in two contiguous leads. Okay, so this is your P wave, this is your Q or S, and this is your T wave, and noted this is your ST segment. So ST segment is always an isoelectric line. So when in an abnormal ECG, what is happening? When there is an elevation in this, okay, when there is an elevation of this ST segment, so this is indicating your myocardial infarction. What does mean by myocardial infarction? There is a sudden decline in the O2 supply to that myocardial region is termed as myocardial infarction. Okay, your cardiac muscle is injured. That is causing the ST segment elevation, right? So what you have to do in case of the management, important nursing interventions, activate the cardiac emergency protocol, and we have to perform the percutaneous coronary interventions, and we have to post the patient for thrombolysis if PCI is not possible immediately. So this particular protocol we will be studying in detail in the upcoming class. Now we are concentrating on the ECG. Next we have ST segment depression. When there is a depression in the ST segment, okay, when there is a depression in ST segment, when there is a depression in the ST segment, it is because of ischemia. Okay, here in case of infraction, lack of O2 and severe form of injury. Okay, severe form of injury, and either particular myocardium is bent for the necrosis state also, near necrosis state, irreversible. So here in this case of ischemia, which means lack of oxygen to the particular period of time, the initial phase of that injury. There it is a complete injury. Here it is an initial phase of the injury. So in this case, you can see the ST depression, horizontal or downward shift, downslopingness of the ST dip. ST segment is termed as your ST depression. So you have to monitor the troponin, oxygen and nitrates, and anti-anginals should be administered. So that if you monitor the basic cardiac biomarkers, you can come up with a conclusion like what is the intensity of the ischemia, right? Next, we have the peaked T waves, tall, narrow T waves, which is seen in hyperkalemia. The most important question point whenever you have a question, tall peaked T waves. Okay, tall peaked T waves. Okay, tall peaked T wave. It is always seen in the hyperkalemia. It is always seen in the hyperkalemia. You have to monitor the potassium level and you have to administer calcium gluconate to revert the hyperkalemia state, and insulin plus glucose plus dialysis if the case is very severe. Next, we have U wave, small wave after T wave. Okay, U wave is prominent. Prominency of U wave. Okay, U wave is prominent. U wave is prominent in case of hypokalemia. Remember T wave first. When potassium is going to increase to the greater extent, I am going to T wave. T wave is the brother we will consider. I am going to come. When the potassium is going to reduce, when the patient is going for hypokalemia, the brother is going to be very prominent. Okay. Okay, the brother is going to be very prominent. That is your U wave. Peaked T wave, tall T wave is seen in hypokalemia, whereas U wave, prominent U wave is seen now. It's seen in case of hypokalemia and digoxin toxicity, right? So you have to replace the potassium and monitor for the other arrhythmias. Next, we have prolonged QT interval. When there is a prolonged QT interval is seen in many conditions. Okay, that we will discuss in the pharmacology, in which are all the areas where you see the prolonged QT interval. The maximal or very prominent, most commonly you can see prolonged QT interval in this particular drug administration is your moxifloxacin. Okay, moxifloxacin is the drug which has the most common effect of this prolonged QT interval. Okay, most commonly QT interval is seen when we administer moxifloxacin. So that is the component in this drug. And QT interval is seen in class 1A, 1B, and other arrhythmic compounds, which we will discuss in the pharmacology sessions. Okay, quinidine, solatolol, and electrolyte imbalances also causes your QT prolongation, which means hypomagnesemia as well as hypermagnesemia, both the condition causes QT prolongation. It's very important. So this QT prolongation is the risk of torsade D points. So you have to monitor the electrolyte, especially magnesium. Avoid QT prolonging drugs, which includes your moxifloxacin, quinidine, your class 1A drugs or antiarrhythmic drugs will cause class 1A, 1C. These drugs causes prolonged QT interval. Please cut to 1C. Okay, class 1A drugs causes QT prolongation, so you have to note it. Next is torsade D points. It is a polymorphic ventricular tachycardia with twisting QRS complexes. Okay, you can see this is the torsade D points. You can see the polymorphic VT. Okay, polymorphic with twisting QRS complexes. So one of the pattern you can analyze is you will be having a synchronized pattern here. Okay, most commonly seen in hypomagnesemia and QT prolongation, torsade D points. When QT prolongation is not treated properly, it will lead to torsade D points. Okay, so magnesium sulfate you have to administer in IV and defibrillation if the patient is having pulseless. So magnesium sulfate is one of the most important drug you have to administer when the patient is going for torsade D points. That is the drug of choice. So what is the most important nursing implication or nursing interventions when the patient is getting and when the patient is getting a magnesium, okay, IV magnesium sulfate. When the patient is getting an IV MgSO4, the nurse should monitor the knee jerk reflex. Very important and multiple times asked question. Okay. So nursing interventions, which is very important when the patient is getting magnesium sulfate, is your knee jerk. The nurse should assess their knee jerk reflexes. Right. So next we have the nursing priority actions, which we will see in the next session. Thanks for watching.